approach in thoracolumbar fracture.
My name is Robert Meves. I work in Santa Casa Spine Center, São Paulo, Brazil. I'd like to thank the opportunity to participate in this meeting and represent Brazilian Spinal Society. I'm going to talk about when to add anterior approach in thoracolumbar fracture with convolution. What's the clinical relevance of this topic? First, thoracolumbar with convolution are 20% of all spine injuries, with 40% in neurologic injury in young patients. The vertebral convolution can cause kyphoid deformities and neurologic deaths because the retroprotrusion fragments into the spinal canal. There are controversial discussion about when we have to perform anterior approach after posterior fixation in these fractures. For instance, this clinical case with thoracolumbar fracture with convolution, we performed posterior approach, but despite we have the compression of spinal canal, we have an implant failure with kyphotic deformities because we don't add an anterior approach in these patients. So we can measure this convolution by using low sharing classification. This classification ranges from 3 to 9 according to convolution, apposition, and kyphosis. So we assess whether it's possible to define the best therapeutic approach based on the low sharing classification. This study was a systematic literature review of randomized controlled trials. You use Embase, PubMed, Cochrane Library, Scopes, Web of Science, Lilex, and the others. These are the search strategy. The population was patients with the thoracolumbar burst fracture. We use load sharing classification to observe in 1 year implant failure with breaks or loosening the screws, loss of correction of segmental kyphosis, loss of 10 degrees of curve, and we correlate with this classification. We split in 2 big groups, less than 6 and more than 6 points. And we use this random fixated models with 5% of clinical relevance. We had 189 papers. According to our criteria, we selected 9 papers to answer this question. Papers around the world. We can see in red some bias risk of these papers. However, these 90 papers are the best papers to answer these questions. When low sharing classification was greater than 6, we had 284 patients with 6 studies. We had 7 implant failures, 14 losing the correction of segmental kyphosis, and 4 patients with both complications. These are the numbers of implant failure, loss of correction of segmental kyphosis, and implant failure and kyphosis loss. By using load sharing classification, we can observe that all cases of up to load sharing 6 would show good results with isolated posterior fixation. So we don't need to add anterior approach in these patients. However, when load sharing is more than 6, the results are unpredictable. So we can conclude the load sharing classification for thoracolumbar burst fractures is reliable when the score is up to 6, and the posterior instrumentation is effective in preventing complications. When the score is greater than 6, other fractures have to be taken into account in order to define the best therapeutic approach. Thank you.
Thank you very much. And next talk is